Welcome to the conference session titled PNH and Non-Transplant Therapies. Thank you for joining. My name is Nyari Sireo, Patient and Professional Programs Coordinator at Aplastic Anemia and MDS International Foundation. As we get started, we recognize the generosity of the corporate sponsors, Alexian, Apellis, Amgen, BioCris, Bristol Myers Squibb, Genentech, Novartis, Regeneron, Servier, and Taiho Oncology, and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there'll be a question and answer session. We will do our best to get to all the questions today. Today's specialist is Dr. Nikolai Podolstev, an associate professor of medicine in hematology. He is the director of the Hematology Leukemia Tumor Board. As the associate director of the Yale Hematology Oncology Fellowship Program and Yale New Haven Hospital Duffy Firm Chief of Education, Dr. Podolstev is involved in organizing and providing hematology education, as well as medical oncology fellows, internal medicine residents, and medical students. With that said, welcome, Dr. Podolstev.
Thank you very much for the introduction, and thank you for the foundation, which invites me not for the first time to do the talks. This is the first time, though, I'm doing the talk on paroxysmal nocturnal hemoglobinuria. So this opportunity helped me to organize my thoughts about this condition. I do take care of this patient, so it was great. I was looking to have this stimulus to organize the slides, and hopefully going forward, we'll be able to help other people to learn about this condition. But today I'll be talking to you, so be with me. This is the first time I'm doing this talk, so there's always room for improvement, but I hope to be clear enough. So no direct conflicts. Perhaps Novartis has a drug which is in the works, and this is something I'll be talking about at the end of the talk, but otherwise these are not related to the topic of my presentation today. So I did show this slide in my presentation on aplastic anemia because these two conditions, aplastic anemia and paroxysmal nocturnal hemoglobinuria, also known as PNH, are connected. So what is PNH? So it's chronic complement-mediated hemolysis, which is damage to red blood cells by part of the immune system known as complement. This happens due to development of a clone. And clone is defined by mutation in PIG-A gene. So I put a pig there so to make it memorable. So it's PIG-A is just the name of the gene, and you can see what it means down at the bottom. So it's acquired and it's X-linked. That means this gene is located on X chromosome. So the result of this mutation is dysfunctional, is lack of this GPI anchor proteins on the surface of blood cells. And these GPI anchors are holding proteins protecting cells, including red blood cells, from complement damage. And complement is part of the immune system, which is constantly on protecting you against infection. So when there is no protection to your own cell, red blood cells, specifically by presence of proteins CD59 and CD55, they get damaged, they get destroyed, they get lysed. So this is called hemolysis. So resulting anemia can cause problems for patients with need for transfusions. Also, thrombotic events can occur because of the release of certain things from the dying red blood cells, increasing risk of clotting in arterial and venous system, mostly venous, as well as there are other clinical manifestations. So this condition, when clinically significant, is associated with reduced survival. I just have to mention that not all of the PNH patients will have these manifestations. So actually, sometimes it's a very, very small clone. And as I've mentioned during aplastic anemia talk, this may be a sign of acquired aplastic anemia, which helps us to differentiate between acquired disease and constitutional aplastic anemia, because it's a sign of activation of the immune system. So biology of this condition of PNH, how the clone becomes bigger. There are a few cells here and there which usually are undetectable, but when your marrow, when your hematopoietic stem cells are under attack by your own immune system, it allows growth of that clone. The cells with PIG-A mutation multiply, and they are functional, they produce progeny, and this includes mature cells, including mature red blood cells, which circulate in the blood, and they're deficient of complement protection, and that's can create the situation when hemolysis can become clinically significant. So this is the mechanism we see in aplastic anemia, where patient's own immune system attacks hematopoietic stem cells and gives advantage to the clone with PGA mutation. So there are also intrinsic factors, because not all of the PNH patients will have aplastic anemia or similar conditions. Intrinsic factors include, in addition to PGA mutation, some other genetic abnormalities which give advantage to cells in this PGA mutated clone. And that can be, different things like an MDS, for example, or, some other mutations which we can see, which do not really lead to additional diagnosis, but, cause advantage to this clone, allowing it to become bigger and clinically significant. So we have to understand the complement a little bit. It's a complex system, but it is a vital component of innate natural immune system. When child is born, there is no adaptive immune system yet. There is humoral and cellular adaptive components. They take time to develop. So this is the primary response a child is protected against infection with. And there are three mechanisms how this complement is activated. It's called classical, lectin, and alternative. The alternative pathway is the one we have most interest in, and we'll talk a little bit more about, but all of this lead to activation of the complement, which attacks infection, for example, to protect you from developing of clinically significant illness. Complement activation can certainly be provoked by infection, but also other things like surgery, trauma, pregnancy, immunizations, and some inflammatory conditions like gout. So the complement system is always on, specifically this alternative pathway. And, so it is on because it requires, it is necessary for the complement to be quick in responding to infection before it kills us. So, and it rapidly amplifies when it encounters infection or other things mentioned previously. There are natural inhibitors which prevent uncontrolled complement activation. This is an important weapon we have against infection, but if it is aimed at us, it can cause trouble. So there has to be mechanisms which regulate its activation and keep it under control to prevent self-damage. So on the picture, you can see that there are proximal pathways, which include classic pathway, lectin pathway, and alternative pathway. These pathways lead to formation of C3b complement component, and C3b then activates C5 and converts C5 to C5b. So this is how the complement responds to infection. And C3b can opsonize the cell. That means this protein attaches to the surface, targets the cell for degradation by the other parts of the immune system, by macrophages in the spleen, for example. And also the terminal pathway leads to activation of number of proteins, and they create so-called membrane attack complex, which basically attaches to the surface of the cell, makes a hole in it, and that causes cell destruction. If it is red blood cell, this destruction is called hemolysis. So there are two ways complement can eliminate the cell, and one of them is opsonization and removal by the spleen, macrophages, and another one is creating holes and just directly destroying the cell. So, so this is going back to the definition, which I hope now is a little bit more clear. So we basically, the patient with PNH has problems with controlling the complement, which activates too much and attacks what it shouldn't attack, including red blood cells, causing destruction of the red blood cells, which may happen in the bloodstream. This is called intravascular hemolysis, or in the spleen, which is called extravascular hemolysis. A resulting hemolysis causes anemia, which may necessitate transfusion support, also increased clotting events, as well as other clinical manifestations. And all of that may be associated with diminished survival of the patient, decreased duration of life. So it is called paroxysmal nocturnal hemoglobinuria, but it is a big misnomer. First of all, it's not paroxysmal. Usually hemolysis is going on every minute, but it may become worse. For example, in certain circumstances, like infection, vaccination, pregnancy. It is not nocturnal, even though it is more common at night, because hemolysis and activation of the complement occurs at night due to decrease of blood pH. So it's a little bit more acidic, and that may precipitate more active complement engagement with red blood cells. Finally, hemoglobinuria. So the urine can become dark, cola-like color. But it doesn't happen in most of the patients. Actually, 17.5% of patients will not have hemoglobinuria. So it is uncommon to see paroxysms only at night when you have dark urine when you wake up in the morning. So nevertheless, that's the name, paroxysmal nocturnal hemoglobinuria. So this slide emphasizes the importance of this condition because it diminishes life expectancy of the patients who have PNH. So it's a rare condition, 4,000 to 6,000 patients living with this condition in the United States. Prevalence is 15.9 patients per million of the population, and median time at diagnosis is early 30s. But all ages can be involved with PNH. So 5-year mortality is pretty high, 35%. And you can see this as survival curves comparing survival of age and gender matched controls with patients with PNH. And you can see the survival difference between two. Age and gender matched controls live a bit longer than patients with PNH. So there are many different clinical features. We already spoke about hemolysis, which is destruction of red blood cells, mostly in the circulation in the bloodstream, but also in the spleen. This can be worsened by certain conditions like pregnancy, trauma, infection, inflammatory conditions. And we can have means of detecting it by not only looking at the CBC and seeing anemia getting worse, but also increasing LDH, which is lactate dehydrogenase. This is the enzyme which leaks out from the dying cell. Not specific for red cell, can be also seen when other cells are dying, but nevertheless, it's an easy indicator to see if hemolysis is worse. Bilirubin is the byproduct of metabolism of dying red blood cells. It goes up. Reticulocyte count, when marrow is working and you have destruction of red blood cells in the blood and in the spleen, your marrow should mount response and increase production of reticulocytes. If there is no concurrent aplastic anemia, that's what you will see, increasing reticulocyte count. Haptoglobin is the protein which binds free hemoglobin in the blood, and it is very sensitive and goes down pretty quickly with minimal amount of free hemoglobin circulating. And there's this direct antiglobulin test which detects other types of hemolysis, and it is usually negative in patients with PNH. Patients with PNH can also have other counts being on the low side, including white cells and platelets. And this is due to marrow suppression by, again, the immune response against hematopoietic stem cells, which we discussed in aplastic anemia. So again, anemia, leukopenia, thrombocytopenia can be seen quite frequently in patients with PNH for that reason. Thrombosis, and specifically thrombosis in unusual sites due to activation of platelets and complement, as well as hemolysis itself. We're talking about cerebral venous sinus thrombosis. We're talking about thrombosis in the abdomen, in the abdominal veins, including a specific condition when thrombosis affects hepatic veins or Budd-Chiari syndrome. Also, arterial thrombotic events may occur that include strokes and heart attacks, not as common as venous thrombosis. The hemolysis leads to decrease in nitric oxide because free hemoglobin binds nitric oxide, and that causes vasospasm, as well as spasm of different smooth muscles. And that creates the situation when patients with PNH can experience pain, esophageal spasm, abdominal pain, kidney and lung dysfunction, as well as erectile dysfunction may be seen in men. So this study looked at single institution patients. They had more than 1,000 patients who had PNH clones. And PNH clones basically may be symptomatic or asymptomatic. The small clone will not really cause any problems, will be just there and detectable. So they looked at all of these patients and they categorized them in two big groups. One of them is PNH with bone marrow failure. These are patients who have low counts, may have aplastic anemia or MDS, and classic PNH, where you have hemolysis and thrombotic events. It turns out that classic PNH is minority of patients, and majority of patients will have PNH with bone marrow failure, either due to MDS or aplastic anemia. So the median age of diagnosis in this particular study was actually 49. Not, as I said, 30s. And these patients with cytopenic disease had two peaks similar to aplastic anemia. And hemolytic patients with hemolytic variant or classic variant of PNH were a little younger than patients with bone marrow failure PNH subtypes. So the classic patients have a higher number of PNH positive cells in the circulation. As I've mentioned, in aplastic anemia, about 2/3 of patients will have a PNH clone, but only 15% of those will have significant size of the clone to lead to, let's say, increase in LDH and some type of hemolysis. So with PNH being larger in classic presentations, it makes sense because these are the patients who have more hemolysis. So this is another study just looking at patients with bone marrow failure, PNH and bone marrow failure. And as I said, there are two kinds of patients here. One group has MDS, another one has aplastic anemia. And the number of patients with aplastic anemia having PNH in this particular study was higher than MDS patients. So there was 18.5% and 1.1%. So LDH was elevated in about 42% of patients with MDS who had PNH and only 18% of patients with aplastic anemia. So the clinically more meaningful hemolysis happens more frequently in MDS. And if you use very sensitive technique called FLAIR, you've heard about this before. So FLAIR helps us to detect absence of GPI anchors. When we look for CD55 and 59, we actually look at the absence of proteins which attach to GPI anchors. But at the end, the important feature of PNH is absence of anchors. So direct detection of the absence by FLAIR is more sensitive than looking for 55, 59 absence. So, these patients, about 40% of patients with aplastic anemia had PNH clone, and up to 2% of MDS patients had it. So, it's very prevalent, but not all of the patients will have classical manifestations, including hemolysis and thrombosis. So who should be tested for PNH? As a clinician, I have to recognize who are the candidates for testing, because the only way for me to know who is suffering from this condition is to know that they have it. So these are patients with hemolytic anemia who do not have positivity of this Coombs test or direct antiglobulin test. They usually don't have any specific findings on the blood smear, and no evidence of infections causing hemolysis. Tick-borne diseases in Connecticut are one of the more common causes of hemolysis, specifically Babesia infection, which is transmitted by a tick. So we have to rule this out, especially during the tick season, during the warm months of the year. Presence of dark urine, it's not common, but if you have it and you have anemia, that may prompt you to do flow cytometry to check for PNH. Aplastic anemia, all of my patients whom I'm following, I check at the beginning and they keep an eye on it periodically after the diagnosis and management initiation. Hypoplastic myelodysplastic syndrome, another bone marrow failure condition, which is commonly associated with PNH, and unexplained low blood counts, cytopenias, because they are frequent. And frequently associated with the PNH. And thrombosis in unusual sites. If someone presents with Budd-Chiari syndrome, thrombosis of portal veins, this would be one of the tests I'm going to order. If someone presents with cerebral venous sinus thrombosis in the brain, that would be another situation when I would check for PNH clone. So the diagnosis is established based on flow cytometry. You had this talk by Dr. Shu earlier today. And historically, this was HAM test. The red blood cells from a patient were exposed to low pH environment, and that prompted interaction between complement and red blood cell membrane causing hemolysis. This is not a very sensitive test, so that's why we're much more sophisticated now using flow cytometry, detecting absence of 55 CD59 on the cell or absence of GPI anchors with FLAIR. FLAIR, attaches to GPI anchors. If you expose cells to FLAIR and then you cannot detect it, that means GPI anchors are absent. So finally, as a lot of patients have cytopenias, bone marrow biopsies in order to help diagnose associated bone marrow failure if it is present. So I will present a couple of patients. This is the first patient, 21-year-old man with severe aplastic anemia who also has concurrent PNH. Initially, he presented with fatigue, shortness of breath, and lightheadedness. He had low hemoglobin of 4, platelet count was 5, very low. White cell count was 2.4, and absolute neutrophil count was 500. So basically, pancytopenia. It is not very severe, but severe aplastic anemia because ANC is 500. For very severe, you have to be 200 or less. Absolute reticulocyte count was low, 17. The definition is less than 60 for aplastic anemia. And LDH, that enzyme which leaks from damaged cells, was elevated at 431. Upper limit normal is 241. Haptoglobin, which binds free hemoglobin, was undetectable. Bilirubin was normal in this patient. So bone marrow biopsy was performed to investigate pancytopenia and showed hypocellular marrow with normal karyotype and absence of other genetic abnormalities, absence of mutations. So fish flow test was done to rule out telomere biology disorder and was normal. This patient is young, so you have to suspect constitutional bone marrow failure. So Fanconi anemia testing was also unrevealing. Presence of PNH by itself pushes you strongly towards the diagnosis of acquired aplastic anemia in this patient. And certainly he had PNH. So in fact, he had significant number of granulocytes and monocytes. This is subtypes of white cells, which lacked expression of GPI anchors. And a red blood cell population was also quite significant, 11%. The reason why it's such a discrepancy is because red blood cells are damaged and they don't survive. So their number is less than white cells, which are not damaged and survive longer. So there's always a minority of red blood cells which lack GPI anchors. And that's why we're using granulocytes and monocytes a lot of times to assess severity of the disease. So he was started on treatment with HEG, cyclosporin, and L-Trombopac, the most effective treatment. You remember that more than 2/3, more than 70% of patients respond to this. But because of this significant PNH component and hemolysis, we also started him on eculizumab or Soliris. So the administration of this C5 complement inhibitor is going through two phases. One of them is induction phase weekly for the first 4 weeks, and then you go to maintenance phase when it is administered intravenously every 2 weeks. So what does it do? So this is normal blood. You know, the complement is activated by different things, including infection, and you can see that it is also on all the time to respond rapidly when infection occurs. So usually red blood cells are protected by presence of GPI anchored protein CD55, which protects you against opsonization with C3b right here, right? You know, so opsonization doesn't happen, the protein doesn't attach and doesn't tag the cell for degradation in the spleen. And CD59, which inhibits MAC, membrane attack complex, so holes are not made in the red blood cell. So that's what happens normally. So complement and red blood cell coexist peacefully because red blood cell is able to control the complement. So, and again, it's proximal pathway and terminal pathway. All proximal pathways end up in terminal pathway and MAC, membrane attack complex. So in PNH patient, because you don't really have CD55 and CD59, you're not protecting, red blood cells are not protected against damage. First of all, they are opsonized by C3b, which tags the cell for degradation in the spleen. And also MAC is now attacking, membrane attack complex attaches to the red blood cells, creates the hole in that cell, and its content leaks out and it dies in the circulation, in the bloodstream. So the eculizumab, Soliris, the drug which was approved for, by FDA for PNH in 2007, inhibits conversion of C5, so it's C5 inhibitor, to C5b, which is an important part of the membrane attack complex. And this type of hemolysis, the intravascular hemolysis, is well controlled with this drug. So certainly it's led to significant improvement in outcomes among clinically significant PNH patient who has clinical significant hemolysis, because these are the patients who were involved in the studies. And one of those indicators, which is easy to measure, is LDH, because if you have hemolysis, LDH is definitely elevated. If you stop it, it's not leaking out anymore from those cells which are damaged in the circulation, and it decreases. So there are two studies represented on this figure. The first one is in yellow is Shepherd trial, where, you know, so single arm study, you can see how quickly after initiation of treatment, LDH normalized. And then, you know, the second study, there was a randomized trial called Triumph study. So here, patients were randomized to receive and not to receive, and you can see that then, you know, after 26 weeks of treatment, they all went on eculizumab. And again, you know, so very rapid control of LDH and normalization of LDH. So of course, LDH is just a blood work result. You know, what are the clinical benefits of this treatment? So this treatment can eliminate or reduce hemolysis and eliminate or reduce red blood cell transfusion dependence. It improves quality of life of patients due to improvement of symptoms, including shortness of breath or dyspnea, fatigue, and pain. The thrombosis risk is significantly decreased. And then, so of course, this was not the endpoint of the study because you have to follow patients for many years to prove that there is survival benefit. But retrospective analysis of those patients who are treated with eculizumab for a long period of time show that in the era of complement inhibition availability, mortality appears to be similar to age-matched controls. So what about side effects? Whatever we give, whatever treatment we administer can lead to side effects. And this is the summary of side effects from the TRIUMPH trial, which was the study leading to approval of eculizumab. And you can see that it's a relatively small study because this condition is not very common. So you had 43 patients in eculizumab arm, and this was a placebo-controlled study, 44 patients in the placebo. So headaches perhaps were a little bit more common in eculizumab, but a lot of other side effects were quite similar in both arms. And in fact, some of them were better. So because eculizumab can control certain symptoms of these patients, like pain, for example. So having said that, there is a big elephant in the room, and complement is necessary to protect you against infection. If you suppress complement, there is increased risk of infection, and specifically risk of infection caused by encapsulated organisms. And the number one infection is meningococcal infection causing bacterial meningitis. So in patients who are treated with complement inhibitors, the incidence of this infection is 0.5% per year. And even with prophylaxis, even with using vaccination, it is still quite high, more than 1,000-fold higher than in healthy controls. Due to this high risk of infection, certain measures have to be taken to prophylax against it. And this is necessitating participation of the providers and pharmacists in RAMS, Risk Evaluation Mitigation Strategies program. This is to decrease the risk of infections. This is to make sure that providers who are prescribing these drugs know how to protect these patients against this side effect. And first of all, we're talking about vaccinations, which have to be administered ideally 2 weeks before initiation of anti-complement therapy, like eculizumab. So if it is not possible because hemolysis is so severe and organ function is so severe that administration is necessary immediately to bridge, and you do give vaccination at the same time as you start the treatment, you have to bridge these patients with antibiotics for 2 weeks. So we have to keep in mind that protection is much better to be vaccinated than not, but it is not foolproof protection. So that's why patients are given this patient safety card, which describes certain symptoms, which have to alert them to call their provider and go to the emergency room. That includes headaches, nausea, and vomiting, headaches and fever, headaches with stiff neck, fever by itself, fever and rash, confusion, muscle aches with flu-like symptoms, and eyes being sensitive to light. All of those are non-specific, and some of them are certainly not always related to meningitis. But nevertheless, you have to give patients some guidance to what they have to be paying attention to. So this is a little bit more on complement inhibition and infection prophylaxis. I started this discussion about eculizumab, but this is true for all other complement inhibitors we're going to discuss moving forward. So risk of infection with encapsulated bacteria, not only meningitis with Neisseria, but also strep pneumonia and Haemophilus influenza. And those vaccinations should be done as well, according to the Advisory Committee on Immunization Practices. You can find them on CDC webpage. But usually Streptococcus pneumonia and Haemophilus influenza are done for everyone. Meningococcus vaccination is very specific and is not recommended for everyone, but for the patients who are being treated with complement inhibitors. So there are two, Menactra and Bexsero we're using, and they're given at the beginning. Then Menactra is repeated every 5 years while you're on anti-complement therapy. And Bexsero is given initially primary series given once a month, 2 or 3 doses. Then there's a booster in 1 year, and then every 3 years while patient remains on anti-complement therapy. So meningococcal antibiotic prophylaxis, if we cannot give it in advance, as I've mentioned before. So what happened to our 21-year-old man? So he received treatment with triple therapy, and eculizumab at the same time. His counts normalized within 3 months after initiation of treatment, and by 6 months remained normal, and his bone marrow showed significantly improved cellularity from less than 5% to 40%. Still not perfect for a 21-year-old. The expected cellularity is 100 minus 21, so around 80%, but nevertheless, much better than it was. Plus, counts are good, so he had complete remission. So Trombopag stopped, and cyclosporin decreased by 75%. So interesting, throughout the course of his treatment, he had multiple admissions with small bowel obstruction. And ultimately, during one of those admissions, it would not improve, and he had bowel perforation requiring resection of the bowel and formation of ileostomy. So this is basically when he had a bag, attached to his abdomen. And, of course, he's 21 years old. You want to get rid of it. So it took us a while to get him there, but in a year, this was reversed. So what the pathology of the specimen was not really conclusive to why he had this. But the thought was that he perhaps at some point before we started the treatment had a thrombosis in one of the smaller vessels in the bowel, and that led to formation of the scar tissue and predisposed him to these events. And thrombosis, of course, is the manifestation of the PNH component. So we, of course, didn't know about this, so he didn't receive any anticoagulation, but with starting of anticomplement therapy, this became protective, and he didn't suffer from any other clotting events. So we continued with eculizumab, and then ravulizumab was approved. It was actually a little while before he had surgery, but we waited until he had surgery, and then after surgery, which was successful reversal of his ileostomy, he was switched to ravulizumab. Ravulizumab is another complement inhibitor, and it's also known as Ultomiris. It is similarly to eculizumab. It works in the same fashion. It inhibits C5. You can see both of them work here. So the difference is that this is a more long-acting antibody. Again, there is induction and maintenance. Induction is basically 2 injections, 2 weeks apart, and then you start treating patients with giving intravenous infusion every 2 months. Significant improvement from the standpoint of quality of life, because now you have to come to the treatment center every 2 months and not every 2 weeks. So they have compatible efficacy with eculizumab, but ravulizumab is of greater convenience to the patient. There's expense-wise, it's actually cheaper to give this medication, and there are fewer episodes of breakthrough hemolysis. So what happened to our patient? So 10 months later, his blood flow showed that PNH clots significantly decreased in size. It's interesting, when you give anticomplement therapy, less red blood cells are destroyed. And in fact, if you do flow cytometry again, the number of red blood cells which do not have 55 and 59 on their surface will increase, right? Because now they survive. The complement system doesn't eliminate them. So, and that is kind of a problem, because as soon as you stop the complement inhibition, they may have severe hemolysis, right? So what we saw in this patient, instead of increasing number of PNH red blood cells, we saw them go down quite significantly to the point when we felt it would be safe to stop the ravulizumab. It doesn't happen frequently. Most of the patients require long-term treatment, but once in a while it makes sense to check. And in his case, perhaps normalization of his marrow, resolution of the processes which led to aplastic anemia perhaps helped to normalize immune system function, which is now suppressed PNH clone, and it became much smaller. So ravulizumab was discontinued, and he is actually doing well for the last 2 years without it. So this is a second patient, a 69-year-old man with moderate aplastic anemia and severe PNH hemolysis. He presented initially with fatigue and pancytopenia. All of his counts were low, but not to the degree as previously presented patient. His ANC was actually 800. This is pretty sufficient to prevent infections. Hemoglobin was the lowest, 7.9. We considered giving transfusions to symptomatic patients when the hemoglobin drops to less than 8, so he did require transfusions. Platelet count 35, so usually we transfuse patients with platelet count less than 10. That's when spontaneous bleeding is at higher, there's a high chance of spontaneous bleeding. So he didn't require platelet transfusions, and reticulocyte count was not as low as you would expect in patients with severe, very severe aplastic anemia. His blood flow showed PNH clone, which was quite small. Marrow showed, as expected, low cellularity. Because of his anemia requiring transfusions, he has moderate aplastic anemia. He was treated with cyclosporin. He had headaches, kidney injury, muscle cramps. All of that necessitated reduction of the dose of cyclosporin. After 6 months, he had complete response and cyclosporin was tapered to a lower dose. Then, all of a sudden, he developed anemia. Hemoglobin dropped to 6.9 with evidence of hemolysis. So basically, at this point, you think maybe it is his aplastic anemia which is coming back. But because of evidence of hemolysis with very high LDH, you understand that there may be other mechanism to why this patient developed worsening hemoglobin and worsening anemia. And this is hemolysis. So PNH, flow cytometry for PNH was repeated and now showed significant increase in the number of cells which are lacking GPI anchored proteins and GPI anchors themselves. So you can see 61% for granulocytes, 57 for monocytes, and red blood cells 4.8%. As I've mentioned, those are always low because they are lyes they're taking out from the circulation by active complement. So he received treatment with anti-complement therapy. We started him from ravulizumab after vaccinating him with meningococcal vaccines. His LDH improved but didn't normalize from more than 1,000 to 386, and his hemoglobin improved to 10-11 range. Then he had hospitalization for colitis, and that made the situation worse. His anemia became much worse. He started to require red blood cell transfusions again. So what happened? So the breakthrough hemolysis is the term which we use for the circumstances like this. And when someone's anti-complement therapy, breakthrough hemolysis can occur for a number of reasons. About 20% of patients who are receiving C5 inhibitors, either eculizumab or ravulizumab, will have breakthrough hemolysis. And there is pharmacokinetic, so-called pharmacokinetic hemolysis. This is when you have suboptimal drug levels, and it is occurring more commonly with eculizumab and rather than ravulizumab. This may be related, for example, in pregnancy to much higher activation of complement, and the standard amount of eculizumab you give to pregnant women may not be sufficient, and you have to escalate the dose to overcome this situation. The pharmacodynamics situation is a little different. So here you have good drug levels, but hemolysis still occurs. And here, this is extravascular hemolysis. Remember, C5 inhibition helps to inhibit membrane attack complex, but there is also C3b opsonization of red blood cells, which help macrophages in the spleen to remove those cells, so-called extravascular hemolysis. And that's the mechanism which can cause breakthrough hemolysis in certain circumstances, including colitis, like in these patients, but also other situations like surgery, pregnancy, inflammatory conditions, trauma. So on the left is familiar schema with eculizumab and ravulizumab blocking formation of C5b and MAC. You can still see that there is opsonization going on, and that's why there is some degree of hemolysis which may continue even with good inhibition of C5. So, and that hemolysis happens in the spleen where macrophages recognize opsonized red blood cell and remove the cell from the circulation. Now here we have pegcetacoplan, the new drug, which I'm going to talk about next. The drug is approved by FDA since 2021. It's also known as Empaveli. And it is a subcutaneous injection or infusion, which patient can do on his own at home twice a week. So this drug actually affects proximal part of the complement, specifically C3. And what it leads to is inhibition of production of C3b, so there is no opsonization, and down the stream, there is no activation of C5 to C5b. So this proximal pathway inhibition leads to elimination of hemolysis, extravascular hemolysis, as well as intravascular hemolysis. So, and that's what we see here on this picture. So it inhibits C3 conversion to C3 and C3b, and there is no intravascular hemolysis and extravascular hemolysis in the spleen. And by the way, it also happens where macrophages are in the liver. So this study looked at patients who were on eculizumab and randomized those patients after initial period of 4 weeks to pegcetacoplan in subcutaneous injections and eculizumab continuous infusions. And you can see that the eculizumab patients had decreased hemoglobin comparing to pegcetacoplan patients. These were adults with PNH and hemoglobin levels of less than 10.5. So those patients were on eculizumab, but eculizumab was not sufficient to improve their hemoglobin to normal. So they still had mild anemia, but not all of them required transfusions, of course. So the primary endpoint was mean change of hemoglobin. And, this was better among patients treated with pegcetacoplan. Secondary endpoint was transfusion independence. Again, pegcetacoplan subcutaneous injections were better. This patient was started on pegcetacoplan twice a week. After ravulizumab was discontinued, you actually have to be careful and you have to continue. So basically, ravulizumab works every 2 months. So usually you give pegcetacoplan starting about a month after you give pegcetacoplan, about a month after you give last injection of ravulizumab. So you still have 4 weeks of protection from ravulizumab while you expecting pegcetacoplan to start working. So there is no breakthrough hemolysis here. And, so that basically led to complete normalization of his counts at this time. He's okay with injecting it himself. This is a infusion at home, but you need a special pump to infuse. The volume is such that infusion has to take 1 hour. If you want to shorten it, you have to have 2 needles under the skin, 2 pumps, and you have to do it twice a week. For some of my younger patients, this is not as acceptable as coming to the office and getting infusion in the office once every 2 months with ravulizumab. But for some patients, it may be more convenient. He did well with this treatment and continues to do well. So finally, I want to talk about treatment of PNH, the future of the treatment of PNH. And so this is the future is in inhibition of proximal pathway of the complement. And specifically, see pegcetacoplan working here at the C3 level. There is factor D and factor B, which support conversion of C3 and to C3b. And if you inhibit them, you can also block this conversion. So there are 2 drugs, which are oral medications, pills, which are being in development for inhibiting factor D and factor B. I'm going to talk about iptacopan because this is the drug which is manufactured by Novartis, approaching a discussion of approval discussion by FDA, and maybe will be approved in the next few months, perhaps in December, January. So iptacopan is a pegylated protein which inhibits, as you can see, factor B, and it is given as a pill twice a day at 200 milligrams. So it is not FDA approved yet. So the study, which was presented at American Society of Hematology last year, showed that this drug was more effective than alternative treatment. Once again, the alternative treatment was C5 inhibition, standard of care, either eculizumab or ravulizumab. And the patients who were enrolled in this trial were adults, 18 or older. PNH clone should be reasonably sizable, more than 10% of either white cells or red blood cells. Clinically significant intravascular hemolysis should be happening and defined as hemoglobin less than 10 and reticulocyte count elevated more than 100. So that kind of exclude patients with aplastic anemia where reticulocyte count is low. So 62 patients and 35 patients were randomized to oral iptacopan or continuation of intravenous anti-C5 therapy. And so what the primary endpoint showed, there were 2 primary endpoints, and increase from baseline of hemoglobin more than 2 in the absence of red blood cell transfusions and hemoglobin more than 12 in the absence of red blood cell transfusion. You can see that this particular medication was associated with significant improvement in hemoglobin for those patients who were on eculizumab or ravulizumab and still had anemia. So the side effects between the 2 arms were reasonably similar. So there was no significant difference other than headache and diarrhea, which were more frequent among patients receiving iptacopan, the oral medication. So I think otherwise there were no serious infections because all of the complement inhibitors have potential to increase risk for encapsulated organism to infect and cause problems. So the 2 subtypes of PNH are managed a little bit differently, right? So the classic PNH, which is thrombosis and hemolysis, when these patients are symptomatic, they also have dyspnea, severe fatigue, organ dysfunction, severe pain. So these are usually patients with quite large PNH clones, more than 50% PNH granulocytes or monocytes, and these are just presence of this amount of PNH positive cells increases their risk of thrombosis. Usually, this treatment we prefer treatment with ravulizumab for these patients to C5 inhibit them than eculizumab, other than pregnancy, where eculizumab is known to be safe, and we don't have this data for ravulizumab yet. In patients who present with acute thrombosis, in addition to starting anti-complement therapy, anti-C5 inhibitors, anticoagulation has to be administered usually for the first 3 to 6 months. And then if C5 inhibitors work, afterwards anticoagulation can be discontinued. If breakthrough hemolysis occurs, we can use pegcetacoplan subcutaneous medication or iptacopan, which is not approved yet, but hopefully will be. So infection prophylaxis is important, as we discussed with the meningococcal vaccinations and antibiotics, as well as some of these patients may become iron deficient and folic acid deficient, especially if there is ongoing hemolysis. So iron supplementation, folic acid supplementation may be necessary. In patients who have PNH with bone marrow failure, either aplastic anemia or hypoplastic MDS, you do bone marrow failure directed therapy with IST-NL thrombopag, like for aplastic anemia, or for patients with high risk disease with MDS, for example, allogeneic stem cell transplant. PNH directed therapy may be necessary for these patients if they have PNH associated findings, similar to what we see in classic PNH subgroup. So in summary, PNH is an acquired disorder caused by somatic mutation in PGA, resulting in red blood cells lacking GPI-anchored complement regulating proteins and complement-induced hemolysis or damage of red blood cells. There are a couple of subtypes: classic PNH associated with hemolysis, thrombosis, and organ dysfunction, as well as pain. PNH with bone marrow failure is associated with low blood counts. Diagnosis is established based on results of flow cytometry testing, and initial treatment usually includes C5 inhibitors, eculizumab, or more commonly ravulizumab. Breakthrough hemolysis can occur, and pegcetacoplan is currently being used as the next step drug. Iptacopan, oral inhibitor of factor B, hopefully will become available in the near future. Meningococcal sepsis is potentially fatal complication these patients may experience, and they have to be vaccinated, ideally 2 weeks before initiation of treatment. Anticoagulation is needed for patients who present with new thrombotic event, but can be discontinued within 3 to 6 months after initiation of anticomplement therapy. Allogeneic stem cell transplantation, we didn't talk much about because there'll be a separate talk about this. It can be curative, but there are risks, specifically risks of complications from the allogeneic stem cell transplant, and that's why not everyone gets it, even though it is curative. It is reserved for patients with severe bone marrow failure, as we discussed previously, or patients with severe hemolysis and thrombosis refractory to anticomplement therapy. Thank you.
Thank you, Dr. Podolstev. Do we have questions in the room?
Hi, I have a question. If you recommend bone marrow biopsy for patients who have already have a diagnosis, or if and how frequently you would order that?
So should everyone with PNH have bone marrow biopsy? So a lot of these patients will have low blood counts, not and beyond red blood cells, which are certainly destroyed by PNH. Right, so, and if there are other low counts, I do recommend to do it because there may be co-occurring bone marrow failure related conditions, including aplastic anemia and myelodysplastic syndrome. If other counts are completely normal, you may argue that it is not necessary. So, but, majority of patients get bone marrow biopsy anyway. Right, so if you didn't have bone marrow biopsy and you are on anticomplement therapy and everything is under control, what is the indication for the bone marrow biopsy? So I think a decrease in blood counts. So when your white cell count goes down, when your platelet count goes down, that would, to me, be an indication that something perhaps is going on in the marrow, and that's why you may need evaluation.
Thank you. I have another question. Okay, yeah, sorry, I have another question. So due to the pandemic, I fell behind in my vaccination for meningitis. Do you recommend getting that on a treatment week or an off treatment week, or does it matter?
It probably doesn't matter, so, but I mean, ideally, if you're on ravulizumab, so you have 2 months to get it.
No.
If it is eculizumab, you're doing, every 2 weeks. So do it in the middle.
Okay.
But I don't think it matters in this particular circumstances.
Okay, thank you.
Any other questions? I have a few questions from online. The first one says, I'm a PNH patient diagnosed 6 months ago. After starting to take treatment, infusions, and anticoagulant, I realized that my skin is taking longer to heal. Is this a common symptom, or should I say this may be medication allergies?
It is challenging to say, so again, I cannot comment on individual cases, but in general, impaired healing was not one of the common side effects of anticomplement therapy, right? So, but each one patient is individual and may have other co-occurring conditions. And so that's why I think evaluation by individual physician and dermatologist, perhaps if there's issue with healing, may help in individual cases. So I would not say this is an expected outcome or side effect of the treatment.
Thank you. The next question says the Empaveli injector was recently approved by the FDA. What does this mean for patients?
Yeah, so it's pegcetacoplan. This is proximal complement inhibitor, which inhibits C3. So the FDA approval is blanket approval for PNH. You can use it frontline or second line. The study which looked at this drug looked at it among patients, and I showed you the slide, who still had hemoglobin less than 10.5 while on eculizumab treatment. And to me, this is definitely something I would consider using in a second line setting if eculizumab or ravulizumab are not doing their job and patient continues to have hemolysis. So using frontline setting can be more convenient for some patients, and it is possible, but we have less evidence, for this particular approach in using this medication, but it is approved in both circumstances. Using this medication at home can be preferred by some patients, but in fact, it is a bit cumbersome. And for younger patients, it's probably easier to come to the center and get the treatment there. At least we know that they're getting it. And, so they don't really have to bother with pumps and, subcutaneous administration, which may take an hour, and you have to do it twice a week.
Thank you. The next question says, when does a patient need to consider other treatment options? I'm using a treatment, but I'm still having hemolysis.
Right. So again, Empaveli or pegcetacoplan is approved for all patients, but the study which led to this approval, which, the drug is now approved in 2021, so a couple of years, looked at patients who continued to have hemolysis despite C5 inhibition. So those patients had hemoglobin less than 10.5. So if you're one of these patients with relatively low hemoglobin, there may be, there may be ongoing risk related not only to anemia and symptoms, but also potentially thrombosis. Using pegcetacoplan is a reasonable option. My patient whom I presented was actually frankly anemic and required red blood cell transfusions. So some of the patients who were enrolled on that study had low hemoglobin but didn't require transfusions. So you can argue that these patients can still continue on C5 complement inhibition and not switch to C3 inhibition with pegcetacoplan. So this is somewhat debatable who specifically should be that, so it should move from one treatment to another. But if anemia is symptomatic, especially if you require transfusions, especially if you have other symptoms, it makes sense to try this new drug.
Thank you. The last question is coming from a patient who's asking you to speak a little bit about balancing blood clots, bleeding, and anticoagulants. They say that since anticoagulant would decrease clotting, but however, increase bleeding, which one would you say is worse between the two, bleeding or clots?
So, I'm a malignant hematologist. What it means, I take care of cancer, patients who have a condition like MDS, acute leukemia, myeloproliferative neoplasm, and I do take care of aplastic anemia. So a lot of my patients do have clots for a number of reasons, but I am not a specialist in classical hematology where clots are managed. Having said that, I think I have enough experience to handle this question. So patient with PNH who had thrombosis is actually in an advantageous position to other patients who had clots, because here we know if we have effective anticomplement therapy in place, anticoagulation can be successfully discontinued in 3 to 6 months. The debate is when to discontinue it. And obviously, when you discontinue it, your risk of bleeding goes away, right? So some people, just do it by time, 3 to 6 months. Some would check D-dimer, which is, increased when you have ongoing clot formation, and, would continue anticoagulation if D-dimer remains elevated. But I think it is reasonable to consider discontinuation, especially if there is risk of bleeding. So it's the balance between risk of clotting and risk of bleeding, because both of them may be quite detrimental to your health. And most of the patients certainly go on anticoagulation when the risk of clotting is significantly higher than risk of bleeding. So, but then when you make a decision about discontinuation of the anticoagulation, you take into consideration the risk of clot, which goes down with anticomplement therapy, and risk of bleeding, which remains the same. And if elevated, that would prompt you to stop after 3 to 6 months, and maybe after 3 rather than after 6 months.
Thank you so much, Dr. Podolstev, for sharing your time and expertise.
There's one other question in the audience.
So I just had a question. I've heard physicians talk about liver and kidney damage with PNH, but I've never heard a physician reference the tubular damage. I wonder if you could just describe that a little bit more. And I specifically because I wonder if you know if there's a correlation between kidney stones and PNH, and or if I know dietary kidney stones could be dietary, right? But is there a correlation between PNH or some of the medications perhaps causing kidney stones? And if you could just sort of describe the tubular damage a little bit more.
Yeah, so I'm not a kidney specialist, so I will not be able to tell you beyond that, but we know that there are two organs which are commonly mentioned. To me, it is not liver, so it's, to me, it's lungs, where you may develop pulmonary hypertension, and that can lead to dyspnea. It's nitric oxide, so deficiency of nitric oxide leads to vascular constriction, increased pressure in pulmonary artery, and that can cause, pulmonary hypertension. And in the kidneys, so the damage is also related in part to nitric oxide. And, so I think tubular damage was described among those patients who had biopsies, so again, why is that and what exact mechanism? I will not be able to tell you. I don't think it is related to kidney stones. Now, the question is, can kidney stone increase complement activity because it is such a dramatic event? Perhaps, right? So if you have some kind of event, stress, infection, trauma, all of that can lead to breakthrough hemolysis. So perhaps, that may be the connection, but I'm not aware of the connection between kidney stones and PNH, like PNH is leading to increased number of kidney stones. I think those are separate. And, so kidney stones may be different. Stone analysis can help you understand what the stone is and where it is coming from. And there are specialists who will help you to figure out how to modify your diet, trying to avoid more stones.
Mm-hmm. Thank you.
You're welcome.
Any more questions? Thank you so much, Dr. Podolstev, for sharing your time and expertise with us today.